Thank you for a nice overview, Dr. George. If the microphone continues to be a problem, we'll try to get a lavalier that we can use rather than this. I'll also have to remind to point this microphone down after these other folks talk because they have a height advantage on me. So we have a panel of excellent people to present some information to you, but hopefully have time to answer questions. And I'm going to introduce them individually before they give their brief overview of the information that they can cover. It's nice having a panel like this because when the questions come in, if I don't know the answer, I can turn to one of my colleagues who likely can cover for me if it's an area that I don't know as well as they probably should. And again, this is how I learn, and we all learn about things that we don't know as well or don't know at all. So our next speaker on the panel is Dr. Paul Cullis. Dr. Cullis is the chairman of the Michigan Parkinson's Foundation Professional Advisory Board and holds a seat on the board of directors. Been active with the Michigan Parkinson's Foundation for over 30 years. He completed his undergraduate work at the University of Michigan and got his medical degree in 1979 with a focus on clinical pharmacology in the UK at the University of Birmingham in England. I had to double check that because he works in Birmingham and I didn't want to make sure that wasn't a typo, but he said he went from Birmingham to Birmingham, which is pretty remarkable. He was the chief neurology resident at Wayne State University and received a fellowship in electromyography. He completed additional postgraduate training back in the UK at the Department of Neurology at King's College in London, England. He's currently a fellow of the American Academy of Neurology and holds board certifications in neurology, vascular neurology, and the American Society of Neurorehabilitation. He serves as the chief of neurology and the director of the Parkinson's Disease and Movement Disorder Clinic at St. John's Hospital and Medical Center. He's also clinical associate professor of neurology at Wayne State University. So, Dr. Cullis, if you would.
Just click on the line here.
Yep. If you need to switch over to the videos, you can.
No, that's fine. It's perfect. We got the slideshow here. Ooh, security alert.
Cancel? Is it cancel? Or enable? Do you want to get your video on there?
Enable. All right. Boy, this is very impressive. I mean, I can't believe how many people are here. It's wonderful that everyone came, and I think it's going to be very, very interesting sessions throughout the day. We are going to talk a little bit about what's new in the medication treatment for Parkinson's disease. And I'll start off with a disclosure that I've been paid to do research and to present talks by a lot of different drug companies, so you should probably take everything I say with a grain of salt. We already heard a lot about the general information about Parkinson's disease from Dr. George. The bottom line is that there are now more than 1 million patients in the United States with this disease. It's becoming increasingly important, and as the population ages, the disease is becoming more and more common, and so it's a very important thing for us to understand. This is a disease of older adults. Very few people present under the age of 40, and as Dr. George said earlier on, the average age of onset is around 60. It's a chronic degenerative disease which progresses, and that produces challenges for treatment because we have patients who are going to be taking medications for many years, and the medications have side effects, and so we have to develop strategies that minimize the side effects. The course of the disease is that it has insidious and slowly progressive onset. The rate of progression varies. One of the things that we're asked most often in the office is, how long am I going to be able to do this, that, and the other? And fortunately or unfortunately, you really can't predict. People progress at different rates. And one of the things that makes people disabled is the postural instability, which develops later in the course of the disease. And as I always say to the residents and medical students, treatment for Parkinson's disease has to be individualized. There is no cookbook. You can't just start everybody on the same medicine and progress the same way because patients have different features. We don't really know what the causative factors are. It would appear, as I was just hearing next door, that this is a complex interaction between genetic and environmental factors, which are now beginning to be understood. There are rare families with autosomal dominant and autosomal recessive inheritance patterns, but those are a minority. As Dr. George indicated earlier on, there are a number of medications that are used to treat Parkinson's disease, and he showed you a paradigm of how to start treatment and to progress, which many of us use. The advantages of L-DOPA, and L-DOPA is the drug that most of us refer to, we're buzzing, most of us refer to as Sinemet or carbidopa-levodopa. That's the combination that's available in the United States. It's the most potent anti-Parkinsonian drug. It has immediate therapeutic benefit. It's easily titrated. It may reduce mortality. In other words, it may make you live longer. And it is the lowest cost medication that's available. The disadvantages are that it has no effect on the disease course, no effect on a lot of the symptoms of Parkinson's disease, and the biggest concern is that motor fluctuations and dyskinesia can develop over time. Dyskinesia everyone knows about. It's the involuntary movement that you see most prominently in Michael J. Fox. A lot of patients with Parkinson's disease, as the disease progresses, develop dyskinesia. They have wearing off of the medication. They have freezing. They have on-off. They have other features that we refer to as motor fluctuations. So the chronic effects of L-DOPA include dyskinesia, motor fluctuations, and hallucinations. And so those are things that we are trying to avoid. Wearing off is when you take your medicine. You know that when you have mild Parkinson's disease, you take a yellow Sinemet, it works, you feel great. You take another one a few hours later, and there's kind of a smooth effect throughout the day. As the disease progresses, you take the Sinemet, you feel it work. About 3 or 4 hours later, you feel it stop working. You take another one, and then it starts again. And this is a non-physiologic pulsatile stimulation of dopamine receptors. In a normal person, the cells that Dr. George showed you in the basal ganglia, in the substantia nigra, produce dopamine at a certain level. They make some dopamine, there's enough, they stop. The dopamine is used up, they make some more, and then they stop. So there's what we call autoregulation. There's just the right amount of dopamine. As the disease progresses, we lose that regulation. Sometimes in a more advanced disease, other cells take over in the synthesis of dopamine, like glial cells, the supporting cells in the brain. And so the difference is that the way the normal cells work is like a cat. You give them a whole bunch of food, they come and eat some of it, and then they go away and rest, and then later they come back and eat some more. They know how much they're supposed to eat, and everything works well. As the disease progresses, they're a little bit more like my beagle, who if you gave her a 10-day supply of food would just eat the whole thing and then throw up. So that's what's happening is you take the L-DOPA, your body makes a whole bunch of dopamine, you move too much, the dopamine's gone, you can't move. You take some more L-DOPA, the dopamine's gone, you can't move. And so that's what we call a non-physiological pulsatile stimulation of dopamine receptors. In other words, you're getting pulses of dopamine, and that's what we believe causes a lot of the motor fluctuations in Parkinson's disease. So the goal really is to provide continuous stimulation of the dopamine receptors. This is a slide that really just shows that if you look at people with young onset Parkinson's disease, after 5 years of taking L-DOPA, almost all of them have dyskinesia. So what we tend to do is to try to delay the addition of L-DOPA until later in the course of the disease, starting, as Dr. George pointed out earlier, with other forms of treatment in the beginning. Often we use dopamine agonists in the beginning. These are drugs which are known by names like Requip and Mirapex, or the Nupro skin patch. These drugs are very effective in mild to moderate Parkinson's disease and tend to cause a lot less long-term side effects. What we would like to do is have continuous stimulation of dopamine receptors. This abnormal pulsatile stimulation of dopamine receptors is a problem, and so recently a number of medications and other treatments have been introduced which aim to produce a more continuous dopamine receptor stimulation. One of these that we just mentioned is that the Requip and Mirapex come as extended release preparations now, which produce a flatter effect, and also there's the Nupro skin patch, which generally is absorbed through the skin continuously and produces a continuous effect. So some of the things that have been tried recently include the extended release agonists. That first line is incorrect. I apologize, it's a typo. It should say extended release ropinirole, which is Requip, ropinirole, and pramipexole, which is Mirapex. There's the Nupro skin patch. What also has come about recently is a more continuous release levodopa carbidopa preparation called RightRe. RightRe is a drug which goes into your gut and slowly releases the carbidopa and levodopa over a long period of time. One of the problems with the drug is that it's very expensive, and a lot of insurance companies don't want to pay for it. One of the other things that you'll see demonstrated across the hall is a therapy called Duopa. This is a treatment where a catheter is put through the skin into the intestine by a surgeon. It's a fairly simple procedure. The patient then wears on the outside of the body a cartridge which contains gel, and in the gel is basically Cinemet. And this cartridge is slowly, the contents of the cartridge is slowly pushed through into the tube that goes into the intestines, and this produces a constant level of L-Dopa in the blood, which is what we're after here. Obviously, another thing that can be used is deep brain stimulation. Deep brain stimulation is continuous stimulation. It's on all the time, and it's not pulsatile. Another form of therapy that is available in Europe but is only under investigation in the United States is a subcutaneous infusion of apomorphine. This goes under the brand name ApoGo in Europe, and apomorphine, as you saw from Dr. George's slides, is another dopamine agonist. And this is kind of like an insulin pump where the apomorphine is being pumped under the skin at a constant rate to be absorbed inside the body. And that is something that may be available in the United States in the future. The effect on long-term motor fluctuations is still to be determined. We believe that if we continuously stimulate dopamine receptors, we will get less of the motor fluctuations. But that really requires long-term studies. This is a demonstration of the Nupro patch, and what it shows is that if you put a Nupro, which is rotigotine, it's a dopamine agonist, if you put this patch onto your skin, it produces a very constant level of the medication in your blood to stimulate the dopamine receptors. This is a slide looking at RightRe, and what this demonstrates is that over a long period of time, the RightRe produces a constant level of L-Dopa in the blood rather than the pulsatile up and down that you see with the immediate release yellow Cinemet. This is a slide showing the effect of Duopa gel. That's the infusion therapy going directly into the gut that I talked about a little bit earlier on. And this produces a very constant plasma concentration of L-Dopa in the blood, which can be beneficial. And I'm not going to show the deep brain stimulator slide because I think that other people are going to talk about that. But basically, the deep brain stimulator goes under your chest, it goes into the brain, and it produces constant stimulation of dopamine receptors. So that's another method of continuously stimulating dopamine receptors. So what I've tried to show you is why we would like to constantly stimulate dopamine receptors, why pulsatile stimulation of dopamine receptors is bad, and what things are new that are available that further that goal. So what we would like to see is that patients who have mild Parkinson's disease would be treated with things other than L-DOPA. When L-DOPA is introduced, it's usually added on to the other treatments in most cases. And hopefully we can use in the future forms of L-DOPA which produce more constant stimulation of the dopamine receptors and try to avoid some of those very annoying and disabling motor fluctuations which occur later in the course of the disease in patients, especially young patients who are treated with conventional L-DOPA therapy. Thank you.
So I'm on deck next. How are we doing on the sound? Is it okay still? Okay. Good. So probably comment to all of our speakers. We're given topics that could easily encompass the entire time, and it's hard to boil it down to 10 minutes, and I'm sure every single one of our presenters would say the same comment. So I was given the task of covering all the new things that are going on in neuroprotection in Parkinson's disease. To me, this is the most exciting area. It's what I focus all my research efforts on in the lab and in the clinic and in clinical trials, because one of the most common questions I get from patients and family members is, gee, Goudreau, hey, come up with a cure, would you please? When are you going to cure Parkinson's disease? So if you think about Parkinson's disease, it starts off fairly mild and relatively easy to manage with many of the strategies Dr. Cullis and Dr. George have outlined. So it's really not a major issue, but the disease gets worse over time and things accumulate and it becomes more difficult to manage and disability accumulates. If we could find the disease at its very earliest stages and prevent it from getting worse, there's your cure. It turns in from a disabling disorder to something that's annoying. You have to take medication, but you could go on and live without much in the way of symptoms. And I think that's, in my lifetime, I hope where we'll get to in terms of curing Parkinson's disease. So anybody recognize the picture on the slide? Who's this fellow rolling the rock up a hill? So this is Sisyphus, who is doomed to push this rock up the hill. And this is what it feels like to be involved with neuroprotective research. So this is not a new concept. James Parkinson, who discovered Parkinson's disease, long ago, early 1800s, said, gee, we should find something that slows down the progression of this disease, and we're still looking. So let's define a couple of concepts of neuroprotection in Parkinson's disease. This is a graph that shows on the y-axis loss of dopamine neurons and other cells now we know in the brain also decline in Parkinson's disease as a function of time measured in years or months on the x-axis. And what happens is you lose neurons over time. You lose neurons normally with aging, but it's accelerated in Parkinson's disease. Once you lose a sufficient number of neurons, you start to develop clinically evident symptoms of Parkinson's disease that a doctor can diagnose. So that's clinically manifest Parkinson's disease. But one thing you notice there's a fair amount of loss of cells that occurs before the disease even becomes clinically manifest. But early on, as I mentioned, symptoms easy to treat, easy to manage, sometimes not really requiring any treatment at all because they're mild. But they do get worse over time. Disability accumulates, and that's what we're trying to prevent. So if we can find people just at the moment of disease onset when they become clinically manifest and give a drug that prevents things from getting worse, we can affect close to a cure for Parkinson's disease. Since we're intervening after the disease process has already started, we call this secondary neuroprotection. The holy grail, of course, is to identify the people that are at risk of developing Parkinson's disease but have not become clinically manifest, and then give them a neuroprotective drug that prevents the loss of neurons or slows it down so that they never develop symptoms in the first place. Now, you might imagine that this would require us to have a reliable biomarker of pre-manifest or preclinical Parkinson's disease, which we don't have right now. So that's one big area of research in neuroprotection, is finding these preclinical biomarkers of disease. I'm not going to go into any detail of the specific medications, because as I said, if I did that, I could be here for the entire hour talking about biomarkers in the drugs that are being developed. But if we intervene before the disease becomes evident and prevent it from ever manifesting, this is what we call primary neuroprotection. So scientists are hard at work. There's armies of scientists working on this idea, because everybody's compelled by this idea of being able to prevent the onset of disease and prevent disability. So we know a lot about the biology of Parkinson's disease from a variety of different sources. We know these things from families that have inherited forms of Parkinson's disease, cell models and animal models of Parkinson's disease, and from epidemiologic studies of people in the population and how they respond to things in the environment and medications that they take. They give us clues as to what are the areas that we can target for neuroprotective development. So this is not our problem. We do not lack targets, and we do not lack drugs to interact with those targets. In fact, we have the opposite problem. We have too many targets and too many drugs to pick from. How do you pick the best horse, to finish the race? So that's one of the challenges that face us when we think about developing neuroprotective therapies. There's thousands and thousands of drugs and targets that we can pick from. How do you pick the best one? So things like blocking cell death pathways, antioxidants, which have been tried for about 3 decades and don't seem to work, things that improve mitochondrial function, prevent excitatory effects of neurons in the brain that tend to damage other neurons, increase nerve growth factors, which are neurotrophic factors, preventing inflammation in the brain, that's neuroinflammation, dealing with the abnormal protein aggregation and accumulation that occurs in cells that die in Parkinson's disease. If it's alpha-synuclein, that's where a lot of the efforts are focused at finding ways to decrease alpha-synuclein production, increase the clearance of alpha-synuclein, or prevent it from aggregating, but other proteins are targets as well. And then a lot of these things interfere with trafficking of things within the nerve cell and seem to disrupt that, and there's ways we can find to enhance neuronal trafficking that may be another mechanism of neuroprotection. So not a deficit in targets, not a deficit in drugs that interact with those targets. So we got to get these to you folks so that we can help you. How do we do that? Well, we have to go through the stages of clinical development. This is our pipeline. There's 3 main stages. There's a preclinical stage, which I've just described to you. That's where scientists in the lab find targets and drugs that interact with those targets. And then things pass muster and are look to be suitable to use in humans. They can enter in clinical trial phases. There's 3 phases of clinical trials. Phase 1 is where they give the drug to normal, healthy people, usually college students that need a fast buck. And it's basically to find out how the drug distributes in the body, how long it stays in the body, whether it gets chewed up by the liver, gets eliminated into the urine, how long does it last, how much do you have to give to affect a certain outcome. Phase 2 is when they first start using the drug in a small number of people that have the target disease in question to make sure that the drug is safe to use in the target population. That's the main purpose of phase 2 clinical testing, just to make sure that it's safe to use in the target population. They're not designed to prove that a drug works or not. Phase 3 is where the rubber meets the road. We call these pivotal studies. These are the efficacy studies that the FDA looks at to see whether a drug passes muster for an effect like disease modification. Then once it's approved by the FDA, there's research that's often done after the drug is marketed to people to make sure that it behaves the way that it's supposed to behave, or if there's any other unrecognized benefits of the drug for that matter. The graph that I've shown, the bar graph on the other side of the slide, is 2 years old, and it describes drugs in development for Parkinson's disease and the various phases in which they're being developed. So there's a few that have applications submitted, but most of them are in various stages of phase 1, 2, and 3 clinical testing. And this encompasses not only neuroprotective drugs, but symptomatic drugs to treat the symptoms of Parkinson's disease. So there's a lot of things in the pipeline, and I think that's good hope for the future. Let's talk a little bit about clinical trials, because this will come up in answering your questions, and I want to clarify a few concepts for people that aren't clinical trialists, and I don't probably guess that there's a lot of people that are clinical trialists. How many people here have participated in a clinical trial for Parkinson's disease. I give you my many, many thanks. This is the only way for us to move forward. I consider clinical trial participation a pay-it-forward system. Every therapy we have available to us right now exists only because there's somebody before you that volunteered to do a clinical trial to prove that that drug was safe and effective for use in Parkinson's disease. And the only way we're going to find new drugs is for people to participate. So I'll get off my soapbox then. Let's talk a little bit about trial design. There's 4 basic trial designs for neuroprotection. The first one is basically a randomized placebo-controlled trial, which is shown up in A here, where you take a group of people with the Parkinson's disease and you randomize, half them get a placebo, half people get the active drug, and you follow them over time, and you pick an endpoint that's your measurement or barometer of progression of the disease. Therein lies the main problem. Clinical markers of progression are fraught with difficulty in interpretation. Another way to do it is give everybody enroll everybody into the study, and again, randomize them to placebo or a study drug, which is shown in B here. But if the drug in question may have some direct impact on the symptoms of Parkinson's disease, you have to get rid of the direct symptomatic effects of that drug to make sure, to see whether or not that drug has any neuroprotective effects. So you have to have a washout period. So you have people enter in the study, randomize them to treatment or placebo, and then at the end of the study, you have them discontinue the drug for a period of time so that the drug leaves the system, and you can evaluate what they look like off the direct effects of the drug. Now, the problem is, for a lot of drugs, we don't know how long their biologic effects last. So sometimes we think they're going to only last a couple of days, and it turns out they last for 2 months. And if we've designed our washout phase to only comprise, a week, and it really lasts, the direct effects last a couple of months, we've confounded our study. One way of getting around that is doing this thing called delayed start design, which has become a little bit more popular. So you take the population of people with Parkinson's disease, you randomize them initially to a group receiving placebo and a group receiving active study drug. And then halfway through the study, everybody that started on placebo gets converted over to use of the active drug, and then you follow them over time. And that's an attractive trial design, but the problem with this one is our FDA has a little bit of difficulty interpreting the results from this and deciding whether or not it shows any neuroprotective effects or not. The last one is a great strategy to weed through all those drugs that we've already developed to find the best horses. So trials with Parkinson's disease require hundreds and hundreds and hundreds of patients because the disease is slow progressing. We have to do them over many years, 3 to 5 years. So if we went through the thousands of drugs and tested each one of them in 800 or 1,000 people for 3 to 5 years each, you can see that would be a problem. So how do we find the ones that work the best? We'll use this thing called the futility design. And in the futility trial design is everybody comes into the study and they all get placed on the active treatment for a very short period of time, a relatively short period of time. And what this is supposed to do is give you an indication of whether or not that drug has any hope of showing neuroprotection if it were to be used in a larger trial. So it's a way to weed through a lot of those drugs for less time and less money. So this will help get us to where we need to go, hopefully. Now you see that A, B, and C all have a placebo group. So when you go into a clinical trial, a lot of patients ask me, gee, Dr. Goudreau, I'll do the trial if I'm not in the placebo group. Why don't you put me in the active group and I'll do the trial? Well, we can't do trials that way because then we'll never find out the answer. So why not just provide drugs that look like they have promise to people with Parkinson's disease and see if they work? I mean, why are you keeping these effective treatments from us, Dr. Goudreau? We know that they work. Well, the problem is we don't know that they work. Let me give you an example. This came out about a little less than a year ago. Anybody heard this story with Tasigna or nilotinib? I cannot really pronounce that name. This is a cancer drug used to treat leukemia. This got into the popular press because it was given to 12 patients with advanced Parkinson's disease over 6 months. And they used videotapes of these patients who all knew that they were taking the drug. There was no placebo arm. And some of these people showed dramatic improvements in their symptoms of Parkinson's disease on the videotapes. And this, of course, got into the media. And probably everybody on the panel here received several phone calls about people wanting to get placed on this drug. Well, the problem is there can be a placebo response. Anytime you take a drug and know you're taking the active drug, you're going to improve just by virtue of participating in that trial. The second thing is this is a very small number of patients. Most neuroprotection study trials involve anywhere from 400 to 800 patients, not 12 patients. Most neuroprotective studies need to follow patients over years, 3 to 5 years. So this small study, while it's very encouraging and exciting, is no way proof that this drug will show neuroprotection in Parkinson's disease. And in fact, we've seen this story before, multiple times before, and I'll show you a slide of all these drugs that came into the same category that looked like they had promise in these small trials that didn't pan out in larger trials. So we need to do a larger trial to make sure that a drug works. Otherwise, we're going to expose people to drugs either that are not effective or have side effects, including this cancer drug. It's a chemotherapeutic agent. It has side effects. So we need to make sure that it's safe and effective in people before we move forward. So that's why your doctor's not giving everybody this drug just because these 12 patients, a few of them had videotapes that looked promising. So we need Equipoise. What is Equipoise? To do a trial, we have to have Equipoise. Equipoise is required for conducting a clinical trial that poses risk to patients. For a clinical trial to be in Equipoise, we truly don't have to know. We truly don't know whether a drug works. So the investigators really shouldn't know that one arm of the clinical trial would be better than the other. So all these trials that I would describe involve a placebo because we truly don't know whether taking the placebo is any different than taking the active drug. We have to be generally uncertain whether one treatment arm is superior to the other. So when we're enrolling people in trials, we don't really know it's going to be a value for you to be in the placebo arm or the treatment arm. If we did know that it was going to be a value, we wouldn't do the trial. It would be unethical. If we knew this was going to work, then we wouldn't do the trial. We hope it works, but we've been wrong too many times. So really it's essential for obtaining generalizable knowledge. So if a clear agreed upon answer exists, then the participants assume the risk of the research, but you have to know that it'll provide the same information for all people. If we don't do placebo controlled trials, then we're not really going to move forward in our knowledge about how these drugs work and if they're effective. So let me give you an example. Creatine was a drug that we studied. This is what I looked like before I went into neurology. Creatine is a dietary supplement. It plays a role of supporting mitochondrial function, which are the little energy factories of the cell. It's absorbed orally, it's very safe, well tolerated, and showed a lot of promise in neuroprotection in laboratory animal models of Parkinson's disease. And we were very excited about this being a way forward in slowing down the progression. So we did a futility trial and showed that this had some possible neuroprotective effects in our futility trial design. So we designed a large study with 1,800 subjects and followed them for 5 years in the design that I showed you labeled A before. So half the people got creatine, half the people got placebo, and we followed them over 5 to 8 years, and we had this very sophisticated endpoint or measurement of whether the drug was working or not. Unfortunately, we had to halt the study in about 2013 because it was pretty clear that this was not going to show any neuroprotective effects. So we were convinced, probably more convinced than the data that you saw with this Tasigna drug, that creatine was going to work, and when we moved to a larger study, it didn't pan out. And this is all the drugs that have been studied to date. It actually goes on longer than this, so you don't need, these are all the drugs that we've tried. We've been trying. None of these have worked. None of these have worked, and all of these have had compelling data to suggest that they might work, but when we tested them in clinical trials, they haven't worked. So this is where my idea of Sisyphus comes up, is we keep kind of trying to roll the ball uphill, and it's not budging. This is my mentor from Mayo Clinic. He came out with this editorial after one of the more recent failures of a neuroprotective drug trial. So no satisfaction yet. So let me describe a couple of trials that are going on right now to touch on a few of them to show you that there is hope for the future and we're not giving up. Uric acid is a natural antioxidant. We know that there's oxidative damage to cells in Parkinson's disease, and we know that if you look in the brains of people with Parkinson's disease that have damage, the uric acid levels are low in those areas that are damaged. We also know that if you have a low uric acid level, your risk for Parkinson's disease just about doubles, and that if you're a person already diagnosed with Parkinson's disease and you have low uric acid levels, your rate of progression is much faster than if you have normal uric acid levels. So pretty compelling evidence from epidemiology and from the laboratory to suggest that increasing uric acid levels in somebody that has abnormally low uric acid levels may slow down the progression of Parkinson's disease. So we're doing a trial of not uric acid, but the thing that leads to uric acid. So you can't give people uric acid. You give them precursor to uric acid. Your body takes in this drug called inosine and converts it into uric acid, and then that will increase the amount of uric acid. You have to be a little careful with this, so I don't want you to go out to the health food store and buy a bunch of inosine. If you take too much inosine and your uric acid levels are too high, anybody here had gout before? So if you make your uric acid levels abnormally high, that's a problem. It also can give you kidney stones. So we're not taking people that have normal uric acid levels and making them high. We're taking people that have abnormally low uric acid levels and making them look normal. And then we're following these people for 3 to 4 years. And this study has already completed enrollment and is in progress. We should know the answer to this in about 2 to 3 years. The next one that we're just, this one is just starting, going to be just starting enrollment, so it hasn't started enrolling yet. So this is the one that we've already completed enrollment and are following patients, and it's called the STEADY PD study. And they're looking at a drug called Dinosaur, which is an old blood pressure medicine that your doctor could prescribe to you if you wanted. And it prevents the entry of calcium into the cells. And I like Dr. Cullis's beagle analogy. So cells that work hard in Parkinson's disease use calcium to help them signal other neurons. And they let calcium in to help drive signals to other neurons. But too much calcium inside a cell is a bad thing. So it's like a rowboat that has a bunch of holes in it, and you're busy bailing out all the water that keeps coming in. And what these calcium channel blocking drugs do is they plug those holes in your rowboat so it stays afloat a bit longer. So we've enrolled, I'm trying, but you can tell I get very excited about this, and I thank you for reminding me. You can tell this excites me, and I talk faster and faster. So if you plug the holes in the rowboat won't sink. So less calcium coming into the cell, the disease should progress more slowly. And indeed, if you look at people that take calcium channel blockers, their risk for getting Parkinson's disease is much, much lower. So this study has completed enrollment, and this is the one we should know the answer to in 2 to 3 years. The advantage to this drug is it's already FDA approved, and your physician can prescribe it to you, so it doesn't have to go through a lot of the other regulatory things that drugs that don't have approval yet do. So we're excited about this one as well. So those are 2 that are currently underway in phase 3 testing for neuroprotection in Parkinson's disease. There's a lot of work I mentioned focusing on alpha-synuclein. I won't go into a lot of detail on this slide, but alpha-synuclein is a protein in nerve cells that helps them communicate to other nerve cells. But alpha-synuclein is a problem in that if there's too much of it, or it's not made properly, if there's an error in the way that it's made, it becomes sticky and starts to clump up and aggregate. And aggregatable synuclein can cause normal synuclein to start aggregating, and it tends to cause cellular dysfunction. So there's great interest in trying to manipulate the levels of alpha-synuclein inside cells, either by reducing the synthesis of alpha-synuclein, increasing its elimination, or reducing its stickiness and preventing it from causing these clumps. One example is this really cool molecule down here called the molecular tweezer. And I love it because the way the molecule is shaped reminds me of some big spaceship on Star Wars or Star Trek. But this actually can bind to synuclein that's already been aggregated and cause it to disaggregate. And this is a little bit hopeful because it's hard to find a drug that reverses pathology that's already in progress, and this may be one of those drugs. So these molecular tweezers are of great interest and are being studied. They're at earlier stages of clinical trial development than the other drugs that I mentioned, but there's a lot of work on that. There's work on antibodies that reduce the amount of synuclein or vaccines that reduce the amount of synuclein by increasing the clearance of alpha-synuclein. So there's a lot of work being done to manipulate synuclein. Lastly, I'll just wrap up with 2 things. So what's taking so long? Why is it taking us decades to find something that we've been looking for? Well, developing a new drug takes a long time, about 10 to 15 years from its preclinical phase to when it's available to you in the clinic. So it has to pass through this preclinical phase to make sure that it's safe and binds to the targets that we think it's going to bind to. That takes about 3 to 6 years. And you can see the numbers of drugs that kind of pass through this preclinical phase narrow down from about 5 to 10,000 down to about 250 before they even get tested in people. Once the FDA says you can use it in people, few of those drugs make that jump from preclinical over to being safe to use in people. So it goes from 250 now down to 5 drugs. And then through these phases of clinical testing, 5 drugs that enter, only one of them will achieve FDA approval at the end of this. And so this is a long and risky road, and it costs millions and millions of dollars to traverse this pathway. So that's one of the reasons that it's taking so long. Just touch on the challenges going forward. We need to find clinical trial design that account for drugs that have direct effects on the symptoms of Parkinson's disease, so we don't confuse direct effects of the drug for neuroprotective effects. We need to find better ways of narrowing down that giant list of potential drugs to ones that are the fastest and best horses to bet on. And we need to find a way to have a clinical trial that accounts for a disease that slowly progresses, because doing trials that last for 5 years and finding out at the end of 5 years it doesn't work is a little bit frustrating. If we can find a way to accelerate that process, that would be great. And that really centers around finding endpoints that are meaningful and easy to use in clinical trials. And it would be helpful if we had biomarkers of disease progression to do that. Lastly, how can you help? I mentioned clinical trial participation is a pay-it-forward system. A good way to do that is the Fox Trial Finder. Anybody has used this yet, Fox Trial Finder? So I liken this to a dating service for clinical trials. It's like a dating service for clinical trials. You go onto the site, you enter in your information about you and your Parkinson's disease, where you're at in your Parkinson's disease, and it will tell you all the clinical trials that match up with your profile in your geographic area. And you don't have to date any of them. You can just look at them online and learn about them, which is a great way to learn about new therapies being developed. If you're interested in participating in a trial, you can say, hey, I'm interested in that trial. It sends some information to the trial site. Doesn't give your name or phone number or anything like that. The trial site looks over your information and says, yeah, this looks like somebody that would match with our trial. Have them get a hold of us, and then it sends you a message saying the trial site wants you to contact them, and then you're free to contact them at your leisure.
Introduce the next speakers.
Yep. So that's all I have for this, and we'll talk next in a different topic with Denise Van Etten and then Karen Freshwater. Denise is my right hand. She's our nurse coordinator at Michigan State University. We've worked together for, 15 years now, just about. She's been an active member of the Parkinson's Foundation and the Professional Advisory Board, and she's been very active in her role in educating with people with Parkinson's disease, both as a clinical nurse as well as through the Michigan Parkinson's Foundation Orientation to Parkinson's Disease and Living with Parkinson's Disease courses. So I'll let Denise take over.
I thought if I didn't have slides, I might get through this a little faster, so I just did a handout to make things a little quicker. We all know about sleep problems in Parkinson's disease, problems with falling asleep as well as problems with staying asleep during the night. But I'm going to add another layer to that in regards to talking about how our new attachment to our cell phones and our electronics are actually disrupting our sleep. It's very rare that you will go anywhere where you won't see somebody with their face in their cell phone, whether it's on the road, in restaurants, or otherwise, even to the point where kids will text in the back seat so the parents don't know what they're talking about. Clearly our electronics are getting more and more involved in our lives, and even back in 2014, the National Sleep Foundation found that 89% of us take our phones or electronic devices into our bedrooms and even sit in bed and play games, look at Facebook and other types of things. What we are not necessarily recognizing that we're doing is that we are providing both stimulation to our brain, increased stress, increased tension right before we're trying to go to bed. And we're rewarding our brain by playing games and giving it information so that it wants to continue to stay awake. And we develop habits of staying up later and later. And the more you do that, the more you build this habit of staying up, playing games, and actually disrupting your sleep even more than it would be disrupted with just Parkinson's alone. So I did look some information up in regards to trying to reduce our problems with electronics. One of them was keep it out of the bedroom, which is the most logical thing, but very difficult for people whose home environments involve one room where all of their things are there. So it really takes a lot of dedication to kind of turn all of those devices off when you go to sleep so that you can get a sound, restful night's sleep. So there are some things that they say can help a little bit in regards to this. And what I found the most interesting in looking at this is, in particular, our cell phones and the newer cell phones, the smartphones. The type of light they have is extremely bright, and that particular light actually reduces our production of melatonin, which helps us regulate our sleep cycles. So we're actually reducing our melatonin levels and making it harder to fall asleep by using these bright cell phones, especially towards bedtime. So I did recommend turning the light down, trying to keep it farther from your face, certainly trying to, within 15 to 30 minutes at least before you go to sleep, to turn those devices off so that they're not disruptive. And I think the things that we often forget to do are turn off our notifications. So you get your little notification in the middle of the night that wakes you up out of a sleep, or you wake up, can't go back to sleep, you figure, I'll just look on Facebook for a little while. And in our current political environment, who couldn't possibly get upset or woken up or stressed over looking at the Facebook posts that are currently there? So I'm going to encourage good sleep hygiene, which we always talk about anyway, but adding the layer of getting the devices out of your bedroom or at least turned off within a half an hour before you go to sleep. So the most important thing for our brains is to kind of have a routine, a way of doing something regularly that gets your brain and your body ready for sleep, that it knows that you're going to sleep. So many of us have this habit of kind of going through different routines of sitting, maybe reading a book, lowering the lights, maybe watching a quiet program or listening to some music. So coming up with a routine that kind of calms your body and your mind, keeping the lights dimmer and starting to kind of prep your body for going into the sleep phase. So most of it's all written out there, and for brevity's sake, I'm just going to kind of pass that on to you, that this would take some motivation on your part and a little myself included, because I'm really bad about taking my phone, about turning the off switch and having a good night's rest.
I see how Denise always has my back by trying to get us back on schedule, which she does in the clinic for me when we're working together as well. Our next speaker is Karen Freshwater. She's a physician assistant in the neuroscience department at Bronson Hospital in Kalamazoo with a focus on movement disorders. She's a member of the Michigan Parkinson's Foundation Professional Advisory Board. With her leadership at Bronson, there's a new and very active support group that's getting larger by the moment in the Kalamazoo area, and a variety of really exciting exercise programs that she's helped promote. She has encouraged a lot of people in her area to become involved with the care of people with Parkinson's disease and their families. I would also note that Karen and Denise have taken a leadership in championing the walkathons. Denise in the Lansing area, which is going to be at Okemos High School on October 8th, and Karen with the walkathon at Celery Flats Historical Area in Portage outside of Kalamazoo on October 15th. And they really give 100% effort to those, and we appreciate them for doing that. So, Karen?
Great. Great. Thank you, and thank you everybody for coming to this talk. I know this is a kind of a long stretch of time to be sitting there, so I appreciate you sticking around. I'm talking about cognitive changes, and as all you know, a lot of the times this is one area that seems to be overlooked quite often in the doctor's office because there's so much focus on those things that you can see outwardly, which are the slowed movements and the tremor and the walking. So often that will be such a focus in the visits that we forget to talk about how are you doing cognitively, how is your thinking, and what's going on with your memory, word finding. Cognitive changes, often seen in Parkinson's disease, are different than what we see in Alzheimer's, which I'll talk about in a few minutes. So it's important to recognize those differences, and a lot of it, if you think of how Parkinson causes slowness of movement with your muscles, with your walking, think of that as how it's affecting your thinking. Things kind of slow down. It's more difficult to process the information that's coming in. So if you are around a lot of of noise, a lot of commotion all around you. It takes more time for your mind to grab what's going on, to listen to what people are saying, process it, and then actually come out with your responses. So what can happen many times, and I've had this discussion on many occasions with family members, is that they will get really frustrated because they will be speaking with their family member who has Parkinson, and they'll feel like they're not paying attention, or that they're just maybe not focusing on what they're saying. But the problem is it just takes a little bit longer to realize, for that to process in the mind, and then to come up with what they want to respond. And a really good example of this, I had a gentleman with Parkinson's disease who had his own family business, and his daughter had taken over the business. And so I was explaining how the mental processes are more slow in the word retrieval, trying to come up with the words you want to say and how you want to respond, how that is slowed down. She got this horrified look on her face, and I said, well, what's wrong? And she goes, well, I feel so horrible because I've been yelling at my dad because he's taking so long to answer me that I think he wasn't listening. And after that, she had a better understanding, and so the next time I saw her, they both agreed things were better because she was taking her time to explain things more slowly, giving him time to come up with the responses that he wanted to give. Because what would happen before is not only would he be slower, she would get frustrated, which would make him frustrated. So the one thing that makes all of this processing speed slower, the responses slower, is getting frustrated, along with depression. So fatigue, frustration, being overwhelmed, all of those things can enhance the already slowed processing speed of how you're thinking and responding. Especially early on with Parkinson's disease, it is that difficulty with what we call multitasking, and our neuropsychologists would say there is no such thing as multitasking. It's more, you might think you're trying to, but your brain can only function and focus on one thing at a time. If you're driving and talking, you may think you're multitasking, but if an emergency comes up, you stop talking and you slam on that brake. So what we're talking about with multitasking is more the ability to transfer from one task to the next quickly. And that's one of those other really prime areas that is more difficult with Parkinson's disease. And that all relates to the slowed thinking and slowed processing. You can't jump from one thing or another. So it's important to try to slow down, take your time, and really focus on one thing at a time. And I think that will reduce the frustration quite a bit. Cognitive changes are typically seen in about 50% of the people with Parkinson. Now this is not dementia, this is just all of these things I've just been talking about. So it is very prominent, and I would say it's probably more than 50% for the difficulties with the word retrieval, the slowed processing speed, just the slowness of thinking. 20 to 30% of the people with Parkinson's disease will go on to develop a Parkinson dementia. I like to think of the glass as half full, so remember that that's 70 to 80% of people with Parkinson who do not develop a Parkinson dementia. This is a lot of the same symptoms with the difficulty with word retrieval, the difficulty making plans and executing those plans, jumping from one task to another, but it is more enhanced, and we think of more of, if we get to the stages more of dementia, it means it is really kind of impacting the daily activities. There's a big distinction between Parkinson's dementia and Alzheimer's, and what we get most often are people who are afraid of Alzheimer's. And a really good analogy that our neuropsychologist uses that I like to use quite often is everybody has a closet in their house or the garage where you store items you are not using. You want to declutter. So you take all those items and you store it in your closet or your garage. Someone with Parkinson's disease, you know that closet's there and you know that you put things there. You might not remember exactly what you put there, but you know it's there and you can go get it. It just might take you a little bit of time to find it. Someone with Alzheimer's disease forgot they even have a closet filled with storage. So I think a lot of times when I give that analogy, it's reassuring to many people because they feel like their memory is terrible and they feel like that it's this frank Alzheimer's, and it most times is not. There are different red flags for people who have Parkinson's dementia. doesn't mean for everybody, but if someone has Parkinson's disease but never had a resting tremor, sometimes that's a little more associated with the Parkinson dementia. And there are also some genetic factors that we clearly won't go into that maybe predispose people to the Parkinson dementia as well. So what can you do to help your thinking and your cognition, your memory? You can go to speech or occupational therapy where they will actually evaluate, and they can give you a lot of clues and tips of things that you can do to help you, using Post-it notes, using a calendar, just writing things down, not trying to do so many things at one time, trying to focus on the thing that you're working on. Try to keep things interesting. Read for learning. Casual reading doesn't seem to help memory as much as actually learning. So learn something new. If you had a hobby that you always enjoyed that maybe you can't do because you're Parkinson, then learn a new hobby. Get involved, stay involved, be active. Parkinson's disease also often makes people feel more isolated. Maybe you don't want to go out, but being socially involved can make a big difference. Join support groups. Exercise. I'm one of the biggest advocates of exercise. Every patient that comes in my clinic knows I'm going to lecture them and talk about exercise at some point in our visits. But exercise has been shown to not only help with Parkinson's symptoms, but with dementia and memory. So a good rigorous exercise, find any exercise you can that you will enjoy and you will stay a part of. Be patient with speaking. Have your family members help them to understand. Education, as mentioned before, is critical. Understand what Parkinson is and how that affects your thinking and your memory so that others are aware and so that you can cut down on the distractions and everyone, when you're speaking, will understand what's going on and be more patient. Have more structured activities instead of just winging it. Maybe you grew up as one of these people that didn't like to plan and just wanted to wing it. Instead, try to plan a little more so that it's clear what you're going to do and so it doesn't get so frustrating. If there's depression or anxiety, both of these can worsen memory, processing speed, and all of that, so treat depression and anxiety. Treat your sleeping. Sleep apnea can affect memory, so it's very important if you do feel like you have sleep problems. One of the things you can do is go for a sleep study, and they can evaluate the excessive movement at night, the REM behavior disorder if you're acting out dreams, or the sleep apnea, all of which can make you more fatigued during the day and affect your memory. Neuropsychologists have wonderful tests, usually take 3 to 4 hours, but they can look at all the different domains of your mind, how it's working, where there might be a problem, and then they can also offer techniques and things that you can do to help. A lot of information out there on brain games, but unfortunately those haven't really been shown to improve cognition as much as, and in fact I think one of the groups recently was sued. But that doesn't mean you shouldn't do those things because you're still wanting to get involved and you're still wanting to be active. I listed medications. There's not a lot of medications who have a robust effect on memory, but it doesn't mean that they can't be tried. Using the other tactics really are the best thing you can do. Thank you.
So now we come to the questions for the panel. We've collected quite a few questions that we're distributing to some of the speakers. John, do you want to go first with one from your pile?
Try to rotate. Maybe I don't have to do that. All right. All right, now it's working now? All right. So I'll do a couple of quick ones and I'll pass the mic off. So one question is this idea of uric acid and low uric acid levels seem to confer risk for Parkinson's disease. And if you have Parkinson's disease and you have low uric acid levels, you progress more quickly. And the question is, has the incidence of PD been assessed in people who have experienced gout? Not directly, but the study that suggests that if you have low uric acid levels, you seem to be protected and your rate of progression is slower. So I would expect that people that have PD and gout have a relatively slower rate of progression, but that has not been studied directly. The second one was the study we're doing with the isradipine, and somebody wants to know how much should I take if I want to get neuroprotective effects. And well, the answer is we don't know. That's why we're doing the trial. The trial is using, I think, 10 and 20 milligram doses, or at least the original one that we did, the safety study. If you were to take it for a blood pressure medicine, I would work with your doctor to take doses that are sufficient to regulate your blood pressure, and then wait to see what the trial results show. And that's a really good question, but that's why we're doing the trial, because we don't know the answer to that. Last quick one, and then I'll pass it off, is can you do more than one clinical trial at a time? If it's an interventional trial using a therapy, you can't. You have to use one trial at a time. If you can do an interventional trial and an observational trial where they're just following your symptoms over time, but doing 2 interventional trials at the same time won't work.
Okay, I'm going to address a group of related questions here. One is that the Parkinson's happens more in older people. Why do younger people get it? And the answer is that the problem with the abnormal protein that accumulates and causes Lewy bodies and Lewy pathology and the loss of neurons can begin at various stages of life. And we think that some people have more of a genetic propensity, and some people have things that they're exposed to in their life that can trigger it. So it just is to some extent a matter of genetics and chance when it starts. Another question is retropulsion part of later stages of Parkinson's or just one of the symptoms? Retropulsion is one of the things that goes along with postural instability. It tends to come a little later in the progression of the disease, but people vary considerably. So it is also just one of the symptoms. And in talking about the symptoms, we have the question, are there other maladies that can mimic Parkinson's disease, i.e. familial tremor? Familial tremor causes a tremor shaking that is generally quite different from the shaking that we see in persons with Parkinson's disease, but in some cases the differences aren't as clear, and that's one reason why the DAT scan was developed and why the FDA says the purpose of the scan is to tell what kind of tremor you have. But in many cases it's pretty clear that you have one kind or the other, but if the symptoms are somewhat mixed, it can be difficult to tell them apart. And similarly, there's a question, is there a relationship of Shy-Drager syndrome? Shy-Drager syndrome is one of a number of different Parkinson's-related diseases that actually have been grouped together as multiple system atrophy. And so there's multiple system atrophy, there's also cortical basal degeneration, there's also progressive supranuclear palsy. All of these together make up a small percentage of people who present with Parkinson's symptoms, but they are somewhat different diseases, both in terms of what goes on to damage nerve cells in the brain and which groups of nerve cells are involved. So these are things that we're always looking for to try and distinguish between different types of Parkinsonism and whether you're one of the more common persons with true Parkinson's or one of these other diagnoses. And finally, are there stages of Parkinson's disease, and is it possible to determine which stage a patient is in? This is a trick question. There's a standard clinical staging called Hone and Yar staging, and most of us always determine each time we see a patient which stage they're in at that point in their progression of disease. But there are other types of staging, and there's one system that involves preclinical stages of various sorts when you might be losing dopaminergic cells but have no symptoms. And obviously it requires very specialized testing to try and sort out what stage someone might be in before they're even known to have Parkinson's. So I'm going to pass the microphone to Paul and leave some of these other questions for later.
I think we should apologize and say that there are 1,000 questions here, and we're trying to pick some of them out and answer them, and I apologize in advance if we don't answer your question. The first one I have here is, are the continuous therapies presented by Dr. Cullis currently available or still under study? Everything I presented is currently available and approved by the FDA except for the apomorphine infusion, which I referred to as ApoGo. That's under investigation in the United States. It's available in Europe. The other therapies are available. However, with some of them, they're quite expensive, and it's sometimes difficult to get insurance companies to pay for them. The next question says, is there any way to help closing eyelids? We refer to this as blepharospasm or sometimes apraxia of eyelid opening. And one of the ways of dealing with that is to inject botulinum toxin into the muscles in the eyelids. One of the toxins that you know about is called Botox, and that can be helpful in people who can't keep their eyes open. And it says, what's the best solution to calm down hallucinations? The best way to handle hallucinations is to minimize the medication that's causing them. In other words, if you're on a lot of a dopamine agonist like ropinirole, which is Requip, or Mirapex, then the first thing to do is try to reduce the medication that's causing the hallucinations. After that, sometimes at the present time, we're using an off-label drug called quetiapine or Seroquel. Seroquel is not approved for this indication. It's a non-approved indication, but a lot of Seroquel is used for hallucinations. There is an application in front of the FDA currently for a new drug called pimavanserin, which we were involved in research on that drug, and that may well soon be available for treating hallucinations in Parkinson's disease, and that would be an approved indication. Next question, once started on Sinemet, is it possible to stop the use and substitute an agonist? Most people in Michigan are diagnosed by their primary doctor, and the primary doctors tend to start everybody on the yellow Sinemet pills. So what happens when I see a patient often, like for example, a 50 or 60-year-old who's taking the yellow Sinemet pills from their primary doctor, I will try to start that patient on some other medication like a dopamine agonist like Requip or Mirapex, make that therapeutic, and then withdraw the Sinemet. So the answer is yes. Even if you've been started on Sinemet, it is possible to transition over to some other medication to try to avoid the long-term side effects. And the last question that I think I can answer is, when is DBS a good idea? Well, I think that in the past we waited too long to do DBS. We waited until patients were very disabled. I think the best answer to the question nowadays is that as soon as patients start to develop motor fluctuations like wearing off, on-off, and dyskinesia, that's probably a good time to do DBS. There's a window for DBS, obviously. If you have very mild symptoms, you don't want to do it. If you're really disabled and ill, then you can't do it because you won't survive the surgery. So there's a window in between where you're starting to get motor fluctuations but still in good health and still at a relatively young age, and that's probably the best time to get DBS. So I'm going to pass the microphone over.
Okay, I think we've run into our break time and beyond. We may want to talk with Debbie about trying to get some of these questions answered in another way. Just briefly, I had several questions in regards to exercise. The overall viewpoint in regards to exercise in Parkinson's is that, yes, it's good. Do we know exactly what exercise or how vigorously? Does weightlifting versus something else provide any benefit? Not perfectly clear at this juncture. In general, because of Parkinson's and how it progresses, we recommend an aerobic exercise as well as a balanced exercise. Now, these can be two separate things, like yoga or Tai Chi, as well as like riding a recumbent bike. Or you can combine them by riding a bicycle on the road, where you have to keep your balance as well as doing aerobic exercise. So in general, exercise is good. I've not heard any particular research or complaints in regards to too vigorous of exercise causing exacerbations or worsening of PD. I certainly do have patients who say that when they exercise, they burn through their Cinemet more quickly, so their symptoms return faster because their drug wears off. One other real brief information in regards to carbidopa, levodopa, and generics in general. For the majority of the population, generics don't cause any major problems. There are some people who are not as good of absorbers of the medication, and sometimes they will see fluctuations from manufacturer to manufacturer in regards to the benefit for their symptoms. If you happen to be one of these people and you find a drug that works better for you, that's the one you want to try to get. Pretty easy for your doc to write, Teva generic only, or one of the other ones, Mylan. There are several of them out there. So it's pretty easy to work with your pharmacy and or your physician to keep the medication that works well for you, and avoiding pharmacies that have a tendency to use the flavor of the month and switch your pills all the time.
All right, I'll cover just a few questions here. One, what role does music have in treating Parkinson's, not just listening, but learning? That kind of goes with what I was saying as far as learning something new. It is the act of learning that helps your memory and cognition. Learning music would cover a couple of different things, because music, the beat of the music, is very helpful for symptoms. So I think if you could learn a musical instrument, that would be very good. Singing, in addition, helps with that soft voice that's often accompanied with Parkinson's. So sing and learn to play a musical instrument, and you've got it all wrapped up into one thing. Does depression result because Parkinson patients can't do anything, or because or does PD itself cause depression? I think that's a really good question, and could be a very long talk in and of itself. Depression, when you think about it, just when someone is diagnosed with Parkinson, it's just that time where you have planned retirement and you have all these things and you've saved up money, and then suddenly there's a diagnosis of Parkinson. So I think depression is multifactorial. Not only do you have this life-altering disease that you've been given that doesn't have a cure, but also dopamine is involved with the motivational, the pleasure center of the brain. So it's a double whammy. So I think you have to just really try to stay positive, try to stay involved, and having a lot of support from the family can make a big difference with depression. And there's a breakout session on that as well later today. Does Parkinson's patients with dementia know they're slipping mentally, or do they start to become less aware? Also a good question, because I think it can be a couple of different things. Often when any of us forget things, the first thing you think is, oh my gosh, do I have dementia, something going on? But we also tend to play it off as, oh yeah, I'm just getting older. So I think there can be an awareness, but for many, you don't want to acknowledge it. So whether they're aware or not, there may be that resistance to acknowledge. Driving is a huge factor and the most difficult thing to address in any visit, because the slowness of thinking will also change the reaction speed and the ability to make those quick determinations in driving, and that's a very difficult decision. And so what I usually recommend when there is concern of that nature and the family is more concerned than the patient seems to want to acknowledge, is I try to take the heat off of the family members, and I recommend the neuropsychological testing, because that way it's not the family members saying, hey, this is a problem, you can't drive, you can't do these other things, you can't be alone, etc. It's getting the formal testing so that they can really identify where is the problem, what is the extent of the problem, and what can we do about it.
Maybe take a quick break, get out, grab something to drink, maybe there's some snacks, bathroom break. Thanks.
Actually, two one-liners. One of the questions was about the relationship of Vietnam service to Parkinson's. Way too complicated to discuss. I just want to say any veteran with Parkinson's who was exposed to Agent Orange should talk to someone at the VA about service connection. And the other question was about nilotinib. More data was presented about this last week in Vancouver at the Academy of Neurology. And one thing that was very clear is that most of the patients were demented, and it was unclear how much of the improvement was related to improved alertness and motivation. Thanks.